Good evening, and thank you for joining us for the first edition of our Town Hall segment called Matters of Healthcare. My name is Camille Curries, and I'm the founder and president of BC Healthcare Matters. We know you could be doing a lot of other things tonight, but you've chosen to join us to raise awareness and get further informed. And for that, we thank you very much. To become an effective advocate, you must get informed and you must speak up. If you find our segment informative this evening, then we encourage you to share the recording that will be available on our YouTube channel at BC Healthcare Matters with all your contacts. We need everyone in this province and across this nation to advocate for the changes we so desperately need. Before we get started this evening, I would like to take a moment for acknowledgement. We acknowledge and respect the Lekwungen peoples on whose traditional territory we are speaking from, and the Songhees, Esquimalt, and Wasanic peoples whose historical relationships with the land continue to this day. So before we get started with our guest speakers tonight, we're going to give you just a little bit of information and share some facts with you. Also this evening, working in the background with me is a few of our BC Healthcare Matters directors and team members. They'll be watching the YouTube chat box for any comments or questions you would like to ask tonight. Speaking of which, I'll take a moment to highlight for you, in case you're new to YouTube, that you can submit comments and questions in the white chat box to the right of this video. You will need to click on the submit button and it will ask you to set up a channel. Without doing this step, you won't be able to comment. Alternatively, if you'd like, you can submit questions or comments to us by email through our contact us button on our website. So without further delays, let's get on with the evening. First of all, I'd like to give you a little information about who and what BC Healthcare Matters is. BC Healthcare Matters is a grassroots patient advocacy group. I started the group back in January 2022, and it has grown into a formidable team with a huge supporter base. Our Facebook group has over 4,000 followers. Last year, the Health Critic of British Columbia presented our petition in legislature with over 50,000 signatures demanding change. And we have developed countless ally connections to help inform us on the ground level matters. We are not affiliated with any political parties, and we do not receive any donations from any political parties. All of our donations come from the wonderful residents of British Columbia and Canada, and we thank you so very much for that. So if you would like to donate to help us keep the political pressure on, please go to our website and click on Support Us in the top right-hand corner. BC Healthcare Matters mission and my mission as president of this society is for everyone in BC to have timely access to a family doctor. So before we get on to our hot topics tonight, let's just go over a few of the facts that you may or may not be aware of that exist in BC right now. Over 1 million residents are without a family doctor, and many more without timely access to the family doctor they may have. 68% of the West Shore of Greater Victoria is without a family doctor. 40% of Kamloops is without a family doctor. 25% of Victoria Metropolitan is without a family doctor. We also have 64 vice presidents across multiple health authorities, earning an average of between $300,000 to $400,000 a year. Whereas our neighboring province, Alberta, has only 7. And in case you're wondering, that does come out to nearly $25 million a year spent on bureaucrats. That's $25 million a year not going to front-end healthcare workers, $25 million not providing for the people of BC through primary care. BC, as you will note in this week's media reports, has the longest wait times in the entire country for walk-ins. And let's be honest, that's only factoring in those lucky few who actually get seen that day, not those that return day after day, hoping to become one of the few that then maybe might be able to wait 161 minutes to be seen. Urgent primary care centers across our province, last reported being at an average of 53% fully staffed, with the lowest staffing rate of 34% being at the West Shore Urgent Primary Care Center, where there are 0 walk-in clinics for the population of 88,000 people and an estimated 60,000 of them being unattached. Many rural communities rely on hospital sites for both their acute care and primary care. Yet many of our rural communities have seen their hospitals close for multiple days, leaving residents with no options for care except to travel to the next city, which could be hours away. People have died because of this crisis. They have died in ambulances while traveling to the next town with an open hospital. They have died in ER waiting rooms, waiting to be seen. They have died because their cancers were diagnosed too late and they were no longer eligible for treatment. These deaths are only but a few of the tragic losses, and they are linked to the primary care crisis, causing a cascading issue throughout our entire healthcare system. So let's get down to talking about that. Tonight, we're going to talk with 2 doctors that work in Victoria, British Columbia. With the most recent announcement of additional federal funding to health services, it's important we have conversations like the ones we'll have tonight to highlight that money alone will not fix the crisis we are facing. Management of the healthcare system and delivery of health services needs to be reformed before any new money will be truly effective. At BC Healthcare Matters, we believe in primary care as the foundation to our healthcare system. To reduce cancer treatment wait lists, we need more family doctors working in communities that can take over the primary care of patients that complete their cancer treatments, versus them remaining on the oncologist patient roster list and creating a barrier for new patients to be seen. To address the alarming fact that it is estimated over 50 women a month in Victoria go without maternity care due to a shortage of maternity-trained family doctors, we must talk about the barriers those physicians and patients are facing. To address our overburdened hospitals, we must discuss how many primary care needs are being addressed in the ERs when they could be handled in community practices if access was available. We have 30 urgent primary care centers open in this province, with potentially another 20 to come. Yet those that exist are not meeting the political promises or providing the needed access. And yet our government says nothing about this. We have to hold our politicians' feet to the fire and call them out when there is a lack of transparency and accountability, because we are the taxpayers and access to healthcare is our right. I would now like to take a moment to introduce my 2 lovely guests this evening. Our first guest is Dr. Vanessa Young. Dr. Young has been a family doctor in the Western communities since July 1996. She teaches medical students, residents, and is qualified in sports medicine. She was also a director on the board of the South Island Division of Family Practice from 2014 to 2022, the last 5 years as chair. She believes strongly in equitable access to community-based, patient-centered, culturally safe primary care for all British Columbians. Thank you very much for being here tonight, Dr. Young.
Thank you for having me.
Our second guest is Dr. Fred Voon. Dr. Fred Voon is dually trained in family medicine and emergency. He's a speaker and author of Inside Guide to the Emergency Department and How to Prevent Having to Go, in addition to roles at UBC, UVic, and the South Island Medical Staff Association. For more information on Dr. Voon, you can look up his website at drvoon.ca. Thank you so much for joining us this evening as well, Dr. Voon.
Thanks for inviting me.
So let's talk. Let's talk about UPCCs, Dr. Young. Now, many of our viewers may not even know what a UPCC is. So let's just explain that first of all. First of all, the acronym stands for Urgent Primary Care Centers. They are primarily government-owned, operated, and managed. There are about you might be able to correct me, but I think 1 or 2 that are run by physicians versus the government, but the government has no longer approved that model to be replicated. The doctors that work in these clinics are paid salaries and sign contracts to be employed there. They are, in the government's words, meant to be centers that would provide for communities' primary care needs by creating attachments to doctors and nurse practitioners, as well as being able to provide urgent care needs to alleviate pressure on hospitals. From our research that we've done at BC Healthcare Matters, we have found that the average cost for establishing one of these urgent primary care centers ranged between $4 to $7 million, and their annual overhead budget ranges from about $3 to $7 million. In British Columbia, we currently have, I believe it is 30 of them open at this time, with the government hoping to open another 20, I believe. So me as a patient, I have experienced standing in these lines outside a UPCC, and it's dreadful to say the least. I've talked to people themselves that have gone there to stand there, and if you're there, it's usually because you're unwell or you're in pain, and standing in those lines for what could be hours does not help that situation, that's for sure. And it's also occurred to me that I honestly worry about how the barriers to accessing the urgent primary care centers has become so incredibly pronounced that many people may even be deterred from even seeking care while an issue could be handled in that kind of community setting. And instead they later present at the ER when things are at a severe state, right? So what we've heard from members of our group and people that contact us by email and social media is the people are asking, why is it that UPCCs are at capacity first thing when they open? And why can't they see more people? So my question to you tonight, Dr. Young, is in April 2022, we saw documents that were released by the Ministry of Health that indicated that Island Health Region had the lowest staffing rates in urgent primary care centers across the entire province. And to give you an example, it stated that the West Shore UPCC only had 7 of the 19 doctors that they needed to run at full capacity. And the Nanaimo one only had 5 of the 16. And James Bay in downtown Victoria only had 8 of the 20. So I guess our question to you tonight is, are there specific reasons for why staffing levels at these urgent primary care centers, on the island and across the province are so incredibly low?
Yeah, absolutely. As most of us are aware, there are shortages of all kinds of employees and workers across many sectors in the healthcare system. The healthcare sector is the same: nurses, social workers, ultrasound techs, physicians. There are shortages across the board, so no sector seems to be unaffected. I won't pretend to understand all the reasons why, but urgent primary care centers are also short of all kinds of staff, not just physicians. But when it comes to shortages of family physicians, the answer is a little bit more complicated because it's kind of yes and no. There are about 6,500 licensed family physicians in BC, but less than half of those are working in the community as family doctors. And there are lots of reasons for this. Decades of intentional neglect by sequential governments and actually by our own medical association, but that's a whole other story, and maybe we'll have another town hall for that. The reason that most family doctors aren't working as family doctors in the community is that it paid the least and it had the most responsibility of all the types of work that they could do. Luckily, this changed on February 1st when a new funding model has started to correct that, and hopefully more family doctors will come back to community work. But coming back to UPCCs, many family doctors are hesitant to contract with and work for health authorities who do run the majority of the UPCCs. Many physicians don't trust health authorities due to poor relationships in the past and to the desire to remain autonomous. Health authorities don't understand the follow-up nature of family practice care. They've never had to do it before. And they're not experienced in delivering it. And as a result, the processes within most UPCCs are limited to episodic or walk-in care only, with usually a different doctor each time and no continuity, no relationship. The walk-in non-relationship-based care provided in UPCCs is generally excellent quality, but it pales in comparison with that provided by a family doctor who knows you, your health history, your family situation, your economic situation, and will follow your conditions along over many years with you.
Yeah, so that's a great answer. And it does highlight quite a few key things, right, for people to understand. It's not, while we do have a human resource issue, it's like we mentioned about a lot of these issues that have to do with the crisis we're facing. It's more than just one factor, right?
Mm-hmm.
And so I really appreciate you highlighting, that there are several other factors to this. And, one of them being, as you said, there's a distrust with health authorities. And I can attest to, I've interviewed several doctors, many doctors that have worked in urgent primary care centers, and they do resonate exactly what you're saying. So, yeah, that's an area we need the government and the health authorities to explore further, right? For our for these centers to perform at the capacity that they're supposed to. So I guess that kind of brings me to the next question, which is, these centers, they have two parts in them. They're called primary care centers and they're called urgent care centers. And when the health minister announced, that these new centers would start to open, there was a lot of highlighting the primary care aspect. And they went as far as to release government documents that said that UPCCs were going to be able to be a location where patients could expect to get a permanent attachment to a primary care provider. And I think that was a key part that clenched, that sold this model to the people, to the government, to the health authorities, and even to the doctors that all originally did sign up for a lot of these urgent primary care centers. But referring back to the documentation that we saw again last year, in March 2022, the health minister finally released numbers for us. And the facts said that across, at that time, I believe it was maybe 24 urgent primary care centers that were open. And there was 19,500 patients that were attached to either a nurse practitioner or a family doctor in an urgent primary care center. And I have my own thoughts about this, but what I want to know from you is, what should the people be thinking right now when they hear 19,000 attachments? Is that a number that people should be impressed by? Like, does it seem to actually demonstrate that UPCCs are creating those permanent primary care attachments that the government promised to us? What's your thoughts on that?
Thank you for asking. So it works out to what, 750 attachments per UPCC? I didn't do the math on how many hundreds of millions of dollars that is, but no, it is not a lot of attachments. And yes, we should be very concerned. As you said in the opening, the annual budget for the UPCCs ranges between 3 and 7 million. The annual budget for the West Shore UPCC, which is the one that I'm most familiar with, I know a bunch of the doctors who are working there. I was involved in a little bit of the very early discussions in planning that one. Their budget's 4 million. So you get half a dozen part-time doctors, half a dozen nurses, 6 receptionists, a team of cleaners, administrators, managers, social worker, counselor. They provide about 25,000 walk-in patient visits annually, which works out to be about $160 a patient visit. That's for walk-in care. So we're not actually talking about attachments right here. To compare, in my clinic, we have 4 doctors, 3 receptionists. We provide longitudinal care to 4,500 patients. We also provide about 25,000 patient visits per year at a cost of about $50 per patient per year, 1/3 the cost. If the 4 million from each UPCC had been directed to the community, 300,000 patients could have been attached to about 300 family doctors. And if you spread that over 3 years, that would have attached just about everybody in BC.
That's
this
so
million
wild,
patient,
right? That's so
right
alarming.
now. And all of that money went into these UPCCs and continues to be poured into them.
Yeah.
Our
And
government, I feel, is grossly misspending our tax dollars, and they refuse to acknowledge this fiasco. And in fact, they're actively hiding this information from the public. And I'll speak a little bit more on that later.
yeah.
But just back to attachment. So attachment by definition implies a relationship with a doctor. This requires the doctor to have committed to working in a clinic long term, which very few doctors have agreed to in our UPCCs, due mainly to distrust of health authorities. Few doctors committed to attaching means very few patient attachments, and that's what we've seen. A little bit more about attachment. So there are some people here in BC who have never had a family doctor. Attachment to a family doctor is the gold standard for primary care around the world, and it's been proven time and time again in research to be the best care. This kind of care meets what we call in this field the quadruple aim in healthcare, which is the best patient experience, the best provider experience, the best health outcomes, and is the most cost effective. British Columbians deserve to be attached to a family doctor. We do not deserve UPCCs.
Yeah, that's a super powerful statement right there in itself, and I really hope everybody hears that tonight and that watches these recordings after, because we need people to start thinking about that, right? Is that the best place to be spending our money? We talk about money nonstop. There are battles between our provincial and federal government all the time over needing more money. But are we using it the best way that we really can right now? To, as you say, the main goal is to provide patients with the best quality of life and the best opportunity to live their very best life. Yeah, I just find those numbers so staggeringly alarming, and frankly, they should be utterly embarrassed by it, in my view. Like, yeah, 26 urgent primary care centers and only 19,000 attachments. It's shameful. And yeah, thank you for breaking down those numbers, because that really brings it into perspective as well about how much more that these interactions are costing us versus investing into community practices. Okay, my next question for you though, it links into this, right? So it's that we know we've done research, we've tried to find data on urgent primary care centers. I know you've done some of that, some of your colleagues have done some of that, trying to access information so that, as you were just talking about, so that we the people and you guys, the health professionals, can really understand as well how much money is going in and out and how much benefit are the people of BC getting from it. And so, I felt a little encouraged last June, because in last June 2022, the health minister said, yeah, I agree. This is important for the people of BC, my fellow MLAs, to all know what's happening in urgent primary care centers, how staffed they are, how many interactions are occurring, which means how many people are being seen by doctors per day, per week, per month, and what's the cost benefit analysis on all this. And so I was really encouraged, because what he said in the middle of question period was that he's going to provide that data to all of us every quarter. So every 3 months is what he promised. And I have scoured everywhere and I have not seen such documentation come forward. And so I guess my question is, has the health minister kept his promise to the people of BC to disclose these numbers? And so have I missed a report somewhere? And otherwise, do you think that the numbers that we've discussed around the staffing rates and the attachment rates have changed a lot, like since 2022 or since June, when those numbers were last released? And does how does this matter if they are different? Like, do you think that it would be helpful for us to have access to that information? Would it be useful in our future decisions to be able to compare the data that was there last year to what's happening now, right? So I guess I'm feeling just really confused and frustrated over this issue, because well, I'll let you tell me first if I missed a documentation somewhere, like, where is this report? Where are the numbers for the people?
Yeah, It's a great question, Camille. And no, I don't think you've missed any report. The numbers may have changed, but I suspect if they had improved a lot, we would have heard in numerous repetitive press releases. Instead, we've heard crickets.
Yeah. So again, right, this brings us back to our topic of accountability and transparency. And it's really hard to trust in the government, trust in the health authorities that they are always making the best choices for us, the patients, when they're not keeping their promises to us either, right? And so that's just another one. Again, last summer making that promise that they'll help keep us more involved and informed. And well, it's really shameful to hear that hasn't happened, and that it's not that we've gone and missed something. It just seems like the information hasn't been released. So some people might be listening today and, they could be saying to themselves, well, why should I care about how much UPCCs cost to run, right? At least they're seeing people. And so to some people, that's a win. But we often try to highlight for residents of BC why the costs of healthcare need to matter to everyone. Because if we're spending on our healthcare budget in the right places, if we're spending our healthcare budget not in the right places, then we need someone to address that and to take corrective measures, right? And so if we turn a blind eye to how healthcare money is being spent, as you mentioned, the per patient costs, or whether we're actually getting even end user benefit for the investments that are being made, we want the people to know that we will end up silently approving the provincial government to just recklessly dump more money into our healthcare system without ever being held accountable for the spending or the outcomes. And so I hope everybody is kind of picking up on that tonight. That's why we're talking about this, because these numbers really do matter. As Dr. Young alluded to, the care you get in urgent primary care centers is fantastic. These professionals, they know what they're doing. We're not questioning the care that's received in these locations, but we're questioning the effectiveness of spending the money in urgent primary care centers in the state that they're currently in. So I guess I'll put it back to you, Dr. Young. Like, do you have an opinion you'd like to share with us on this? Like, why should it matter how much money we pour into UPCCs? Do you think that there are enough measures in place for us to know whether UPCCs are functioning as promised? Or, should there be audits, and should there be more measures so that we can make better decisions?
Absolutely. You can just guess what my opinion is going to be, Camille. But I'll tell you that 5 years ago, when I first heard about UPCCs coming to BC, I thought, but we don't have an urgent care crisis. We have a primary care crisis. So it's my opinion that UPCCs are providing very good walk-in level of primary care to the very few citizens who actually gain access to them. Less than 5% of the care provided at UPCCs is actually urgent. Now, Fred may have more accurate numbers than that, but that's what I've learned. And that urgent type of care should otherwise have gone to the emerge. But 95% of the care is actually primary care, non-urgent care that these folks need and deserve. It's my opinion that the vast dollars pouring into UPCCs annually should be redirected into the community, into community family practices, to recruit family doctors to care longitudinally for patients, to fund nurses, social workers, and other allied health professionals to support community family physicians and their patients. If there were more family doctors, there wouldn't be the need for urgent care centers. Perhaps they should be changed to after-hours clinics, or perhaps to a different model called community health centers, which care for some of the most needy folks in our society, such as frail elderlies or folks with chronic mental illness or substance use issues. I think UPCCs would be better run and be more cost-effective if they were run by communities and the experts in providing primary care, the family doctors. just a little story about information about UPCCs. In December 2020, I made a Freedom of Information request for the cost and evaluation data of the West Shore UPCC. And unfortunately, but not surprisingly, 100% of the evaluation data, this was pages and pages and pages, was redacted or blacked out so that I wouldn't be able to read it, as it apparently could have or would have harmed the reputation of the health authority and or the government. What does that tell you? The UPCCs are an incredibly expensive and failed election promise and must be exposed as such and must be reformed. The public must demand better use of our tax dollars. I'm thinking maybe we need another protest.
Yeah, well, I can't disagree with anything that you said, and it's often highlighted by people that do come to us and share stories or experiences, very much what you're saying, which is that, there was this model created with an intention, but it's not achieving either. It's not achieving primary care for the people, and it's definitely not achieving urgent care for the people, because I live near an urgent primary care center. I drive by it 3 times a day for different activities I have to go out for, and it always says at capacity. So when it's at capacity at 8:30 in the morning, how does that kid who just sprained his ankle go get urgent care, right? It's not even an option. So yeah, we're always trying to come up with ideas and conversations, like you mentioned as well, though, about, we have these 30 UPCCs now. They're there, they exist. We're not even suggesting that they should be shut down, locked up. There's no benefit to them, not at all. We're basically saying, though, there's got to be better opportunities, better options for how these centers can be run and be able to truly provide residents of BC with, either one or the other, though, as you say, right? I guess that's part of the consideration that needs to take place too, is can they still provide urgent care and primary, and or should they be one or the other? But like you mentioned, the community health center model is really something that I think more people need to understand. And I hope, even more politicians, more MLAs reading up on them, because they seem like a good example of how a center in a community can behave differently than the way the UPCC is, and more effectively, right? Did you have any other last thoughts on the topic of, I guess, reform and transformational change for them, right? Like, I'm assuming your opinion is kind of the same as mine. They're not going away. They're there, and we just want to see them being run and managed in the most appropriate way to benefit the end users, which is not what's happening right now.
Absolutely. Right? Yeah, I agree completely. They absolutely need to be reformed. They can do far better. Yeah.
Perfect. Well, I'd like to thank you very much for sharing and answering all these questions for us. We will have you hang around in case our next topic here, you want to give us a little bit more of your insights on as well. I'm just looking here, though, we do have a question, actually. Maybe I'll run one question by you first. So we have someone here that shares, I went into the West Shore Urgent Primary Care Center and was treated for a bladder infection. But after a week, I still wasn't feeling well. So I went to a walk-in clinic in Victoria. They told me there that they couldn't see the doctor's notes from the UPCC, and so they had to do everything all over again. Why is this information not available from one doctor's office to another, or from a UPCC to another walk-in clinic? And this is definitely a story we have heard over and over. Do you want to provide a bit of an answer for that?
Yeah, I can certainly try. Lots of reasons why health information isn't shared between providers. One of the main reasons, sadly, is that our healthcare system is limited by being not-for-profit, in that there isn't the funding to develop cross-provider information channels. because money is so tight in our system. So unfortunately, a lot of people assume that when they show up at this clinic or this hospital or that hospital, that all of their information should be just immediately accessible by that provider that they're seeing. But this is sadly not the case. There is more and more linking of information between facilities, but certainly not between many small operations, such as my clinic and the next clinic over in the building. There's no way we would be able to share information if patients were to go back and forth. So we are far behind the online banking where you just have it all on your phone. And in the Netherlands, people carry around their health information on their cell phone, and they grant access to whatever provider they are accessing. So it's shared in a very much more effective way. Canada has a long way to go before all the providers have access to patient data, and it's a frustrating and costly runaround to try to figure out really what's happened to somebody when they've shown up in a different part of the province or a different part of the city. It takes time that people don't have to hunt down reports and things like that. It's a shame.
Yeah, absolutely. And like you say, that's what always resonates with me too. It's that it's time wasted for the patient, time wasted for the physicians. We're always talking about those administrative burdens. This is part of those administrative burdens that you guys face, right? Well, thank you, for expanding on that. I mean, I can also share that what really surprised me is that we've lived in other provinces. And so when we moved here to BC, I was a little bit gobsmacked that we didn't have a system in place because, when we lived in Alberta, it didn't really matter what walk-in we showed up at or which hospital we had to go into or even what city. My kids had to be seen in some other cities for different specialists, and the information was so easily shared though. It was all there on a system. And I didn't have to walk around with the binders that I have to carry here in BC. And it's so ludicrous. Yeah,
it is. Yeah, Alberta does a lot of things better than BC, and we could learn from them. But folks are reluctant to do that here. I don't know why.
Yeah. Well, maybe another conversation to explore a little further later on. Thank you very much for answering that question for us. And like I said, we'll have you hang around, but we will now shift our conversation. And what we're going to do is we want to shift the conversation to examine how the primary care crisis plays a part in the ERs and the hospital crisis. So we've all seen it all over the news. It's crazy in our province. Hospitals over capacity. There are hospitals over capacity across this country. And the thing is that you can hear it on the news and you can know it's happening, but sometimes it's still hard to appreciate what it means. And so I'm very aware that some of our viewers tonight might not have experienced a need to use an ER in the last year, or they haven't had any primary care needs they couldn't get cared for by a family doctor. So for these individuals, they may not understand the connection between these two crises when we hear about the primary care crisis and the hospital crisis. And so that's what we now want to, well, I guess, first of all, it's part of as well, like our human nature, right? If we don't experience something personally, we may be less aware of the struggles that another person is facing. And so we'd like to fill in that information gap tonight and help the viewers understand how the two crises are linked. And so that's why we're so grateful to have you here, Dr. Voon, to help us kind of highlight this. So our first question that we have for you tonight, Dr. Voon, is, do you think it's accurate to say that the primary care crisis, which has resulted in millions of people not having a family doctor and many more not having timely access to their family doctor, is worsening the crisis in the hospitals today? And could you share with us how a lack of family doctors, what kind of toll is it taking on the hospital?
Yeah, certainly. I think it's having a big effect, and it has for some time. Hearing Vanessa and you talk about the urgent primary care centers and just the amount of money invested, it just seems like a missed opportunity to me that makes me a bit sad that could have been better spent in the community and bolstering up the emergency departments as is. But certainly, I've seen more and more people going to the hospital through the emergency department instead of through their primary care. And that's a much more expensive model for Canadians to be paying for. It's more expensive for the system overall that way. And there's different components on how I think the community and primary care link to the hospital. And one is the obvious arrivals. So it seems like more and more people are coming in sicker or later because they haven't been able to see a doctor in a timely manner. And like you said, that might be physically. So whether it's late presentation cancer, or I just saw a lady with a finger injury from walking a dog and her leash caught. And if it had been something where she came to the hospital in the first week, they could have dealt with it very easily. But now it's sort of like partially healed, and she's going to have either a bad functional outcome or have to have a more major surgery for it. But the physical aspects are just one thing. The mental health is also just awful. People are really struggling right now, and they don't have anywhere else to turn. There are more people needing help and support than there are services available to provide them. And the emergency tries to be the safety net to catch people from all sorts of different services, but it's hard for us to be everything for everyone. And the other side of it, though, the flip side of the coin is on the discharge. So trying to send people home from the emergency department, or if they're sick enough to have to go from the emergency to stay in hospital, to send them home from hospital, it's also harder and harder to coordinate a safe discharge when someone doesn't have a regular doctor to see them in a semi-urgent way. Let me give you an example. Like if I'm seeing an elderly person, for example, for a heart condition, maybe in the emergency, I can make a temporary medication change that should hopefully help, but might affect their blood pressure or their heart rate or their breathing. And I'm not sure what's going to happen over the next few days. If they're frail enough, maybe I have to admit them to the hospital, but maybe if things roll right, then I'd be able to send them home, and I'd feel more reassured if I knew that they could get into their family doctor in a timely way. If they had one person that was like the captain of their care that I could send my report to and even book, follow-up lab testing for example. So I might be more likely in that 50-50 scenario, if it's unsafe, to admit that person to hospital, and then that fills up the hospital even more. And my sense is, I don't work on the inpatient side of hospital care, but my sense is from my hospitalist colleagues is that patients are having to stay longer so that they can see them through if there's no one to tag into the care, If everyone had a family doctor, if the hospital doctor had a family doctor to call during daytime hours to coordinate care, I think they'd be able to send people home a lot sooner, and we'd have faster turnover, and the emergencies wouldn't be full up. Because the myth, I think, is that the emergency departments are full because of just being inundated by little things and urgent care type of things. It's actually not. It's more so because we have nowhere to work and nowhere to see anybody, because the hospital overcrowding leads to boarding of patients, it's called, where people are stuck in the emergency department admitted, but with nowhere else to go in the hospital and stuck there for days. And so, my emergency department could be full of like 30 or 40 patients stuck there for hours and sometimes days, languishing when they could be somewhere else in the hospital. And that really affects the number of people that we can flow through, and it occupies our nurses. So it makes it really difficult. And that's not even considering the long-term care side of things, where, I've heard stories of patients being admitted to hospital for months or over a year waiting for long-term care and other needs that could be met in the community. So it has this huge trickle-down effect, and people don't see it when they're the one sitting in the emergency department waiting room being blocked by this downstream effect.
Yeah, no, exactly. You really hit the nail on the head there, right? And that's why I wanted to be able to have this conversation tonight, because I think a lot of people, exactly, if you're not one of those people that's sitting in an admitted position in the ER because there's no hospital beds, or if you haven't been a person or a family member that would have that very personal experience to understand, as you said, that people are being held in beds as well because of the concern of how will they manage in the community without supports. So yeah, you explained that all so incredibly eloquently. I thank you for that, because I think it's a big missing piece in our understanding of why the hospitals are like they are. And you kind of tapped right into my next question, which I kind of have a bit of a guess of what your answer will be, but I'll still run it by you. Is so my thoughts and the concerns that have been shared with me that I've spoken to others about is that we need to make sure that we're not thinking of just pouring money into hospitals and that's how we're going to fix the overburdened hospitals. Because if we do that without paying attention to the dire need in the communities and the dire need for the longitudinal connections with family doctors or nurse practitioners or allied health professionals, but in the community, we're doing ourselves an absolute disservice and injustice, is my opinion. So my question to you is, do you think that's accurate to suggest that it would be a huge error for our government, our health ministry, to recklessly pour money, frankly, into hospitals, thinking that that's going to fix the hospital crisis?
Yeah, I think family medicine is probably the most cost-effective way of spending our healthcare dollars and primary care. So, I see the emergency department side now. I have worked in clinics and family practices way back when, but I've been in Victoria working in the emergency for probably 15 years more. And every shift I'm seeing patients that could have been handled in the community, but have presented to the emergency department. And the difference now compared to back then is that before, maybe people didn't know better and came to the emergency department. But now there are more and more people that tell me the story of having tried and failed to access care in other ways. And so they may have tried lining up for the urgent care and missed a day of work and still failed to see a family doctor. Or like you said, they may have been standing in line waiting, but suffering in too much pain, or they just knew their elderly family member wouldn't be able to withstand that gauntlet to try to get in. So the trouble is also the care that I provide in the emergency department isn't necessarily the best type of care for every condition. So in the emergency, we focus on episodic, one-time acute events, and we do that pretty well, I think. So injuries, heart attacks, strokes, and pain crises. So probably the number one reason people come to the emergency department in Canada is abdominal pain, for example. So if you're having an acute kidney stone attack or your first time gallbladder attack, then we're there for you, and we do that pretty well. But for chronic conditions, that would be better served by a doctor that could see you on an ongoing basis. So that, Camille, if you had someone that you trusted, a doctor that you'd built a relationship on even before you got sick, that knew you, knew your preferences, maybe knew your context, like what medications had worked and what hadn't. And as a bonus, was a doctor for all your family members too, and knew your context in your family setting, then that would be a better type of care than what I could provide, even if I had an electronic health record that connected to all the other clinics. And it would be more efficient for you. It would be more efficient for your family doctor that knew you and could just tell what your issue was, in a matter of seconds, as opposed to me having to read through someone's chart every time. We deal in the unknowns in the emergency department, but that takes time. And like I said, it's a more expensive way of doing things.
And yeah, so do you find, I don't suppose you have any ratio in mind, but is there a large volume of people that do come in and it's those chronic issues instead, which is what makes it so difficult to be able to care for them? So Oh, I think you're still muted, Dr.
I don't have exact stats. I can just kind of tell, from my personal gut feel and having worked in the same downtown hospitals for the last 15 years or so. But it certainly seems that those people that are more likely to even fall through that safety net are those that are most vulnerable. It's people with chronic pain. It's people with mental health issues. It's people where English isn't their second language, or they don't have a family to advocate for them. It's hard enough to navigate the system when you know the system, or you have, some of the power and privilege to be able to speak up. But I worry for our Indigenous community. I worry for our new immigrant community. I worry for those of us that have these chronic conditions, and it's like having to start from scratch all over again every time you come in to see an emergency doctor. So I can't say for sure, but maybe half the people that I'm seeing every shift don't have a listed primary care physician. That's at the top of every chart, and it's the first thing I look at almost when I go in to see a new patient.
Well, thank you for elaborating on that. Yeah. So I'm just going to kind of go back to a few stories actually that people might have heard over the last 12 months. And they were horrible. They were horrible stories, frankly. There was stories of residents waiting hours and hours to get care in the ER, which in itself is a traumatizing experience at times. But there was also stories of a mother who miscarried her baby in an ER bathroom. There was a story of a senior who passed away in an ER waiting room on a stretcher. And that was after waiting 2 days for care, which I'm guessing that plays into part of the issue you highlighted earlier, where sometimes people are even admitted, but still just waiting in the ER waiting room. And in the spring, Medimaps provided a picture of national wait times, and BC was the worst in the entire country, and Victoria at that time was the worst in the province. So I'm thinking, like, for our viewers that haven't tried to access a hospital in the last 12 to 18 months, say, how would you describe the demands being put on the ER right now? And would you say that the waits are longer than they should be? Like, is there an ideal wait time that hospitals try to target? And are we hitting it?
Yeah, we're definitely not hitting it. There are CTAS recommendations, it's called, for triage severity and how soon you would see a doctor if you presented with one of those issues. And I can't even look at them anymore because they're so unachievable, unfortunately. And that's disheartening. That causes some frustration for all the healthcare team. We're seeing more and more patients, and the last I heard, from several years ago, what used to be our peak daily volume, like the highest number of patients that we would see in a day over the course of a year, that's now our like regular baseline. So when I show up to work, sometimes I look at the waiting room and I can see the length of stay in the waiting room, and sometimes, unfortunately, it's 8 hours, 9 hours from the time that someone's registered to the time they get to see a doctor. That's a horrible place to spend that amount of time. But imagine if you're an elderly person squished next to crying little kids, and you showed up at 6 p.m. After supper, and they're not being seen till 3 a.m. And everyone's packed together in these tight little spaces. Every seat's taken, and there's people coughing, there's people crying. It's not a nice place to be, and it's hard for everybody, no matter which side of the stretcher you're on. From an emerge doc's perspective, we're trying to rule out the worst case scenario. So we're looking for the life, the limb, the vision threatening illness, and kind of like what you're talking about with some of those horror stories. We're not always there to try to give you an answer as to what's causing your pain, for example. We're trying to rule out the worst case scenario, and it's looking for that needle in the haystack. And the trouble is, when the haystack is twice as big, it's harder and harder to find those things. So it's easier. I have sympathy for some of those waiting rooms where it's more likely for an error to happen. It's more likely for a really bad hidden disease to get missed in all of that. there's more and more shifts for our doctors to cover, more shifts than there are people to work them. And meanwhile, we're also being called to go to rural and remote areas to help cover those spots. If I can speak on behalf of the healthcare team in general too, what I'm seeing is that we're burning out our staff, our nurses, our unit clerks, our techs, our housekeeping staff, and we're losing good people and experienced people because it's so hard, the work. In the emergency, we never close, we never turn people away. And so when we're running short 5 nurses and there's no unit clerk, so a nurse has to fill in and do that duty, it makes it harder and harder on those people that are remaining. And not only short staffed, but short resources, short time, emotional reserve, brain power, everything seems to be in short supply. And so it makes it harder and harder for your healthcare providers to do their best work, to do their most conscientious and compassionate, empathetic work.
Yeah. So do you think that like the waits for ERs, actually, I'm just going to refer back to a question here because it is a question that came in from one of our viewers, and it's a really great question, which is, are you able to pinpoint where or when you started noticing this overwhelming shift of patients to ERs that should have been heading to clinics, and how did you cope with that? Yeah, and sorry, and the rest of the question you kind of got to already. So yeah, but it's an interesting question to ask. Are you able to pinpoint any time? Like, when did this all kind of get out of control for you guys?
Yeah, I think it's just been a gradual decline over, more than a decade. I think we've known about some of these problems. I've looked back at some of the position statements from our national CAPE, which is the Canadian Association of Emergency Physicians, and they had canary in the coal mine type of warnings more than 10, 15 years ago. So it's not a new problem, but it's changing. And I worry that it's a lot easier for the politician of the day to slap a shiny new project down, as opposed to, rebuilding from the bottom up, or having the courage and the leadership to make a high risk, high reward decision, whether that's, national licensure, or imagine if there was one national health record. In New Zealand, I worked there for a few months. I think they just had sort of one option. And so it was a lot easier for a new doctor to show up and move to different clinics because it was the same software. I guess what I've seen lately that's new is that I'm fortunate in some ways in that I did some training in family medicine, but some of the emerge docs that work beside me only train in emergency care. And so they've spent their lives training to be a resuscitationologist, and in intensive care, trauma, the worst of the worst. They get their kicks from the high adrenaline stuff. And it's, I imagine, disheartening for them when there are all these conditions that they didn't have the experience and background and training, and felt like it was maybe someone else's job, and now they're faced with that condition in the emergency department because the patient has nowhere else to turn. There was a survey for our local group of about 50 emerge docs, and we asked our group, has burnout from work impacted your patient care in the last 6 months? And 70% agreed or strongly agreed, unfortunately. And we've had a bunch of people leave and not enough people filling in. 84% of people report being verbally abused or verbally assaulted in the last 6 months. That's 84% of our emerge docs. And that's low compared to the emergency nurses that take the brunt of it. So I think that's a symptom of patients being really stressed and burnt out as well, and it makes for a high tension environment.
Yeah, and I've heard that come up recently. We've seen some media about it, and I appreciate the way you rounded out the end of that conversation, because I think that's what's really important to recognize here, is that it is absolutely not acceptable for medical professionals to be treated in that way. But just like we're always saying how we need to examine how we get to places so that we can understand how to get to a better place. It's also important to examine why patients are behaving in that way, right? And there will obviously be some individuals that have some mental instabilities that maybe make it more difficult for them, but there is a very large portion of patients right now presenting to ERs that are likely just beyond frustrated, have given up on the the failures in their community, the failures of this government to be able to provide for them in any other environment. And unfortunately, especially when you're not feeling well and something's bothering you, we don't tend to come in with the most level-headed approach. And so I can absolutely understand how doctors and nurses are getting the brunt of it. But I really hope as well that having these conversations will help patients understand as well how important it is to still come into those environments with a level of understanding and compassion for the people that are working in this failed system. We know what it's like to be experiencing the failed system, but that doesn't make it a free-for-all to try to take it out on the medical professionals either, because you guys are just doing your very best as well to try to get through this. So I appreciate you highlighting that, because I think that's also a very important conversation we need to keep having. And one of the other things that I just want to highlight and maybe ask you about as well, because I think it's important as well for, right now, a lot of times I'm speaking to government officials, because they are the ones that really need to make sure they're understanding exactly what all the repercussions are. And one of the things I fear is that when we have our ERs and hospitals so inundated with primary care needs, I can only assume that that does also imply that there are delayed assessments and delayed treatments that happen for individuals that are actually there needing acute emergency care right now, right? And so this additional primary care pressure on the emergency rooms is actually jeopardizing lives that need the hospitals to perform in their capacity as emergency buildings, right?
Exactly. Yeah. And there's no reserve, there's no buffer. It's always overcapacity and just trying to scramble to try to see the sickest patients. But you're right. It's there's times that because providers and the team and the emergency are so busy handling as much as they can, it's hard to find that needle in the haystack and deal with it.
So I've got one more question for you here, and I'll also encourage our viewers to make sure they've posted their questions if you'd like us to address those in our next little bit here of Q&A. But my last question for you then will link back a little bit to our last question with Dr. Young, which is, when we are talking about the urgent primary care centers, do you think that there is a place and a need for having urgent care centers in the communities? Like, we know that right now these establishments are nowhere near performing in that capacity, but do you think that that is something that should still be considered to be maintained in communities, and that would be also a way to help alleviate some of the pressure on the hospitals?
Yeah, it's not necessarily my area of professional expertise, so I'm speaking more personally. I did work in a standalone emergency in Edmonton that, you could do casting, could do ECGs and blood tests, and do pretty much everything that an emergency department could, but was based in a different part of the city. And it was only if you needed to be admitted to hospital that then we would transfer. And that capability isn't replicated in any of the UPCCs that I know. They're quite limited in what they can do. So I worry it's almost like the worst of both worlds. It's not quite as good as an emergency department, and certainly not as good as a family doctor. And from what I've seen working in walk-in clinics, and what I've heard from the UPCCs, is they're just not delivering that care in a very efficient way compared to what your what you can see if you let a family doctor run a walk-in clinic on the side of their clinic, for example. I also didn't have any say in sort of the design of these centers, but from what I hear, I think the UPCCs would have been more effective if physician input into the design and delivery was taken more seriously from the beginning and followed through on. What I would prefer to see, I think, is everyone having a family doctor, and in which case there'd be less need for an urgent care center. Family doctors with a reasonable workload, they can create systems that allow for you to have potentially a same day appointment or after hours triage or close follow-up in a way that a UPCC can't. I think there's still some role for new and novel ways of delivering care. So, not everyone works 9 to 5. A shift worker, sometimes people come to the emergency room because it's convenient. So having some sort of after hours availability for healthcare other than the emergency department would be helpful. Virtual care has its pros and cons, but the downside to all these different ways of delivering care through different providers is it's so fragmented. You get different people, you get the duplication of tests you were mentioning, you get providers, say in Ontario, delivering care that aren't familiar with the local resources, and so they can't help a patient in BC the same sort of way as a local physician would. And there's the lack of follow-up with the same doctor. So I get that people sometimes don't know if their condition is urgent or emergent, or who they should see first. And so I can totally understand why people show up to the emergency department. In my ideal world, if we could divert some patients that show up in the emergency department to somewhere like an urgent care center after they've had an initial nurse assessment and vital signs, that would be amazing. Even if it wasn't that same day, I'm sure a lot of patients would be happy if they had one central place they could show up to and be told, oh, no, you're okay to go, and we've got an appointment for you tomorrow at 10 a.m. At this other health authority facility. And likewise, I would like to see good transitions in care that are safe. So if someone shows up to somewhere like an urgent care center, but needs the emergency department, that there's seamless integration of care. So to their credit, we're fortunate in our health authority where I think they did take a bit of a leap where there's a high risk, high reward situation in terms of an integrated EMR. At least all the hospitals and some island health facilities are all on at least one system. So some of the computers are talking to each other better, but there's still a lot of sort of legacy faxing of things and trying to get other health EMRs to talk to each other.
Yeah, for sure. I think we still have quite a ways to go on that. And of course, as many will know from my story, we still struggle all the time with that because we have children that have to float between 2 different health authorities for their care. And because of that, there's no sharing of information unless I specifically outline every individual that has to actually be sent an email of the record of information. But then again, that's in an email, and then I'm at the whim of whether they upload it or save it to files. So I'm glad that, regionally, maybe some of it's working a little better, but I really look forward to having more conversations on this topic because I think it needs to be at the forefront. And I am glad the federal government has raised it as a primary concern and need for us to have a more centralized system, because I think it'll save lives. Honestly, I worry about how many people's lives do get jeopardized by lack of consistency of information. It's a lot to entrust people to be the safekeepers of all of their own medical information, especially when they're not at their best condition when they're presenting. I think the one last thought I want to kind of leave with the people, because I think it's something I've had conversations with others about, and I feel like it's kind of my public warning statement today, is that I have concerns as well around urgent primary care centers being called urgent centers. And the reason I have issue with this is because when we first moved to British Columbia and the urgent primary care center in the West Shore was open, to me, the word urgent, it implies something. It implies that if I have a need that needs to be addressed now and can't wait to see my family doctor in, say, 24 to 48 hours, I could go there, and that I could go there if I also don't feel I'm in a crisis state. And so I did make the mistake of assuming that I have several heart conditions. I have a pacemaker. I know that my risk factors for a lot of things are higher. I also am very aware of at what points that I need to present myself at the hospital. However, when we first moved here, there was a couple of occasions where I tried to go into the urgent primary care center for issues that were bothering me, but that I didn't think were necessarily a crisis state, but needed to be checked on this day. And I was turned away, and I was told that no, anything to do with heart, nope, you need to go to the hospital. And so that was a little bit alarming to me. And I always think of newcomers to British Columbia, or as well, people that are visiting our province. If they see these signs that say urgent care, I don't think I had an entirely flawed way of thinking that I thought I could present myself there. And even on another time when I tried to bring my son in there because he had had a head trauma, but had not blacked out, but we just wanted to have him checked, it was the same thing. We were told instantly, no, I'm sorry, you can't be here. You need to go to the hospital because an MRI might need to be performed. So I have issue around the use of that word. I worry about how it might be misleading the people in our community and misleading visitors or newcomers to our province. So again, I think some of those things need further conversation, right? We need to use the appropriate terms and words when we're describing things as well. I'm just looking over here. We do have a few questions. So we're getting to kind of the tail end. So let's go through a couple of these questions. So one of our comments, it's more of a comment and less of a question here, but our follower shares, I drive by the West Shore UPCC every day to drop off my kids at school. And every morning there is a sign out that says at capacity by 8 a.m. So yeah, it's a resounding commentary, right, that we get all the time about these urgent primary care centers. Activities as it doing assigned to do. So another one here is, they're asking, are you saying that health authorities are most staffed by medical doctors? I think what they're actually alluding to here is, I think the question of asking, perhaps, we mentioned how urgent primary care centers are run and managed by health authorities. And so I think they're wanting to understand, saying that they are run and managed by health authorities, are those medical practitioners, are those people with medical knowledge that are running these centers?
They're people, well, I'll take a stab at that. I'm not one of the people who is running those, so this is just based on my understanding of how I've learned how they've been run over the last few years in Victoria, in and around Victoria. Those folks come from the acute care systems. They don't come from primary care because the health authorities really haven't dabbled in primary care until now. The Ministry of Health has mandated that the health authorities start to become involved in delivery of primary care. And it's new language for them, it's new work for them. So these folks who have been tasked with opening and building these urgent care centers and hiring people to fill them and care for patients as best they can, generally don't have a lot of experience in primary care. Now, there certainly are experienced physicians working in them. There are younger, newer physicians working in them as well, but there are a lot of physicians with a lot of experience who are signing up for shifts here and there. But the administrative side of things, the governance of the UPCCs is health authority run and generally not specifically experienced in community longitudinal primary care delivery.
Yeah, and I'd echo that, and that whereas before we saw a lot of private physician walk-in clinics, there's a lot of autonomy and a lot of ability to kind of change on the fly. I think when a health authority is involved, things always move a lot slower. I think of it as a giant cruise ship and just making these tiny little turns with lots of tugboats pushing from the side. And they're also at the mercy and whim of the government. So, you know, a health authority, an individual like a nurse manager or an administrator, they may have the best of intentions and know what the best clinical, you know, patient-oriented outcome and way of delivering it might be, but they may get their marching orders from high up above that says, you know, this is what you're going to do, and their job, their requirement as an employee is to try to fill that mandate. So I think it's there's lots of extra layers involved compared to an older way of running walk-in clinics.
Yeah, and you know, that really surprised me when I started learning about urgent primary care centers and the way that it was expressed to me several times by several different medical professionals that they just felt that they were making recommendations and suggestions that were absolutely needed to be able to ensure the best quality and consistent care possible. And yet the suggestions would be taken and never acted on, right? And I think that continues to remain an issue in the urgent primary care centers, that more weight needs to be given to the suggestions that come from the individuals that are practicing the medicine. Looking to one of our other questions here. So one of our followers asks, when you have a referral from a UPCC, so I'm going to assume they've gone to an urgent primary care center, they got a referral for, say, blood work or an ultrasound, maybe went and had it done at a private clinic. She's wondering if when you then present at the ER, are the physicians in the ER able to access the workup and the lab tests, et cetera, that have already been done outside of the hospital setting?
So yes, every province is different because healthcare is delivered provincially. In BC, we are fortunate enough to have some communication, but our hospital system, if I want to look up someone's results done at a community lab, so Life Labs, I have to click on probably 10 different buttons to get there, and it's not sort of integrated. So I actually have to manually cut and paste or remember those numbers and then put them into my computer note on the hospital side of things. And so when things are in the same ecosystem, hospital to hospital, oftentimes things work pretty well. But some specialists, for example, their clinic notes are just an image of a printout or a fax. And so again, I have to kind of click in there and scroll through it and read it. So it's better than it was. Even speaking to your situation, Camille, even different health authorities, I can click on what's called Care Connect and find out consultant reports and lab tests done on the mainland, for example, or in the cancer agency side of things. But it's not seamless. And Alberta's version's Netcare, each province, I believe, has a different way of doing things. And, you know, to this date, there hasn't been the federal national level oversight and leadership and courage really to make something more seamless.
Did you want to add anything to that, Dr. Young?
Not really. I mean, we have patients who have tests done at the hospital and through that system, and we have patients who have tests, blood work, imaging in other facilities. And it's a matter of some of them are automatically linked and reported into our EMR, and some of them we have to go looking for. So it certainly isn't seamless. It does take time. But with persistence, we can certainly get most results on our patients, but it does take time.
Right. Just a little bit more of that administrative burden all the time, though, right?
Mm-hmm.
Yeah. So we have one other question here for you, Dr. Young. And they ask, if there was one thing that you could do right now for urgent primary care centers, what would that be? Could they be salvaged or repurposed to serve the community? So I think we kind of highlighted that, but it's kind of a good question. Is there one thing that pops into your mind or that you've thought about that is something, you know, if you had the opportunity right now to be making those recommendations, you would say, we need to do this?
I actually think it comes down to governance. And I think the community and patients and primary care providers need to have more of a say in how UPCCs are administered and how they function. And I think they could be rescued, and I think they could be reformed, and I think they could serve communities better, far better. But the community needs to have a say.
Yeah, and I fully agree. That's definitely the commentary that we've heard from professionals that have worked, that are even now still working in some of them, or that have left those opportunities to go do something else, right? The right voices really need to be heard, and we're seeing more and more of them speaking up, which I'm so encouraged by. But now it's really in, the Ministry of Health, the health authorities, the government's hands to make the right choices, right? Who are they going to listen to? As I did an interview yesterday about this new federal announcement, I shared that, my primary concern right now is, yes, okay, we're going to get more money. What I really care about is who's going to be at the table sitting there to help develop the plan about where this money is going to get spent, because that's my primary concern right now, is the accountability and the transparency of how the money is being spent in this province. And I think that it would be a huge misstep on this government's behalf if they developed a plan that did not have the right people sitting at the table, the people that are working in the communities, and frankly, even some of us patients and advocate representatives, because we know what we need. We have heard the stories, we have listened to the stories, we have lived experience that really needs to be taken into consideration when this plan is developed for the federal government.
I agree completely. I think the public has the power.
Absolutely, right? And I hope that the more that we can keep sharing and spreading this information, that the more empowered people will feel, because we all know that often if we feel nervous in certain situations, or we feel unable to speak up about something, it's usually just due to a lack of confidence in the knowledge that we have. And so BC Healthcare Matters wants to keep always encouraging everybody to increase their knowledge based on these issues, because that is how you will feel more confident in knowing what you need and what you need to speak up for. Just looking to see if we've got any other questions here. So this question, I guess one last question for you, Dr. Voon, says here, what happens when a patient comes to the ER or hospital from their family doctor rather than just as a walk-in? How does the information from the family doctor help the ER doctor?
Yeah, there can be several ways of communication. Sometimes it's a direct phone call, and there have been even conversations where if you went to your family doctor and your family doctor wasn't sure about something, they could call either me, or there are some different sort of specialist helplines, call a friend, and it could even prevent needing an emergency visit in the first place. Second of all, if that person is sent in, then I can add in our computer tracking screen a pre-arrival. So that means entering some basic information so that if you showed up to the emergency department, we'd be looking for your name, and there'd be sort of an initial action plan based on some of the information that was already shared with the family doctor. So I could have, for example, blood culture, blood tests, and a CT scan all ready to go, and hopefully expedite the care. Thirdly, sometimes a good old fax is sent with a note sharing some of the concerns and the questions, and some of the so it's not all doom and gloom. Some of the improvements that have been happening behind the scenes involve some of those transitions in care, and I think some of the doctors have been working hard to try to make those better. So if a patient's admitted to hospital, for example, then some family doctors are being sent alerts because they didn't know before, and then patient summaries can be sent on behalf of the patient, where sort of the summary first page of information is sent to those hospital doctors so that the most comprehensive information is developed. So there's certainly ways. Interestingly, in New Zealand, they had a different system as well of I think it was user fees. So if I was the family doctor in New Zealand, if a patient came to me and I sent them to the emergency room, I think there was no charge. But if they went directly, then they had to pay a small user fee. So there's lots of different ways of doing things, even across the world, that we can learn from.
Yeah, for sure, right? I feel like a broken record sometimes, but I do repeat that a lot, that there are a lot of successful approaches, successful models, even some in other provinces in our country and many in other countries. And it's incredibly unfortunate when we don't see those successes being replicated, because that's how we will get through this in, even the most financially prudent and efficient way is to not keep reinventing the wheel, but replicate what works, right? So I guess my last question for each of you, because I will have my own tidbit on answering this one as well, but I'd love to know what you guys think, is for all of our listeners tonight. So many across British Columbia, but we might even have some national listeners. We've been accumulating quite the following across Canada, because as we know, this crisis is across Canada. And so what would each of you say to BC residents that they could do that would be constructive and helpful for, as we say, holding the government's feet to the fire, and for being part of advocating for an improved system, a system that can care for all of us? I'll let you go first, maybe Dr. Young.
Sure. I think the main thing that I would say to that question, what can each person do to make the system better for everyone, is everybody needs to actually realize that their voice does count, and they need to use their voice. I spent a lot of years at meetings trying to fix things in this province, and it actually wasn't until the public voice became loud and angry, and rightfully so, that things actually started to shift. So the power is in the people, and each and every voice is so necessary. And the BC Healthcare Matters website has a whole bunch of tools on ways to get involved, templates for letters if you're not sure how to write to your MLA, phone numbers, how to call to people. Every voice counts. That's what I'd say.
Perfect. Thank you very much for that. Dr. Voon?
Yeah, I'd have to echo that. To learn about the issues. There's lots of books out there. One by Andre Picard that already has a lot of the solutions and roadmaps to making Canadian healthcare better. And two is to speak up. Your organization, I think, lends a real authority, a real grassroots power to a message that doctors alone and healthcare workers alone wouldn't have been able to pass on to governments and those in charge, I believe. Because sometimes if it's just, me saying family doctors need more money and support, it sounds more self-serving. But when it's a collective effort and everyone's saying, no, we all deserve better care, then I think it gets heard better.
Yeah, that's pretty perfect too. That's kind of what I say. We have to all remember that we are all on the same team, right? We are patient advocates, and sometimes people seem to almost forget medical professionals are patients as well. So while it might seem like we're mixing medical professionals and patients together, we're not, because we're all one and we are the same. We are all patients. We all need this system to provide for us. And so we need to stand together on these issues. Well, I'd like to thank both of you very much this evening for all your wonderful insights, your very informed perspectives. And I want to thank you as well for what it is that you do for British Columbian residents and for the work that you do, because it's very admirable. And it speaks volumes of you that you continue to do this work in a system that is often shoving you down, is not giving you the respect or the morale boost and increase that you do deserve for what you're doing. So thank you. Thank you very much, both of you. I'd also like to thank all of you that have joined us tonight. And a huge thank you to my support team in the background that is helping make this happen tonight. We want to encourage you to stay active on these issues. Keep learning and keep asking questions. Most importantly, keep advocating. Come out when we call on you. Come walk with us. Come stand at rallies. Come sign the petitions. Speak up when we ask for your stories and spread the message. Help us raise awareness so that everyone knows about all the details. We have to know how we got here so that we can understand how we get out of here and what our future can look like. At some point, we will all find ourselves in need of healthcare. We must speak up now and act now so that we can get to a system, a place that will care for all of us in our time of need. We must realize that as residents of this province and country, we have the power to bring about the change we need. We are the voters, we are the taxpayers, and we have power. Please sign up to become a supporter of BC Healthcare Matters on our website. Send us a donation if you'd like to help support our efforts to continue to increase public pressure on the government to get us to where we need to be. We will post details about our next town hall on our website under our events page, and we hope you will all join us again. For tonight, have a great night.